whenever we're talking about vascular entrapments, there is the obvious vascular entrapment of the final area right before it gets to the femoral neck, which is through the iliopsoas tendon. But farther up, we have entrapment areas that are possible in the inguinal canal. We have entrapment areas that are possible in the pelvis itself. And any bit of pelvic congestion is going to really have a potential to diminish or entrap blood flow of this downstream branch of the femoral artery. In the pelvis, right above the inguinal canal, that artery is in either the internal or the external iliac artery. And then above that is a common iliac artery, and then it goes into the aorta. So there's areas in the abdominal cavity and in the pelvic cavity that these can get affected as well, especially when we're affecting the area where the obturator artery comes out, which is at the obturator canal. The area of the obturator canal is also an area where the adductor mangus, the adductors, connect into the pelvis and what's the right word? Anastomose or interdigitate or become continuous with the pelvic floor fascia. And the pelvic floor fascia is going to be on the external side of the internal pelvic fascia, which is the endopelvic fascia, which is a very, very rich vascular network. This is why when we can affect that sweet spot at the obturator canal, at that medial side of the hip joint, we clear up a lot of possible entrapment sites. Going back to the adductor mangus and why opening up the adductors is going to be really helpful to affect the pelvic floor, because when we have a lot of tension in the pelvic floor, right, here's a pelvic floor here, when we're a tight ass and our ischial tubes are kind of coming narrower together, what happens is that the inguinal ligament on the front side has a little extra compression across it. And that extra compression of the inguinal ligament is going to have a tendency to have an entrapment of the femoral nerve or femoral artery itself as it transverses underneath in the adductor canal. Also have more of a tendency to press on the iliopectineal ligament. The iliopectineal ligament is a ligament underneath the inguinal canal that maintains the space at the top of that adductor canal, so that when we go into hip flexion or hip extension, we're not compressing the femoral artery. So that's a real important thing to know, that one of the ways to treat that is not just going to be treating directly at the inguinal canal or directly at the iliopectineal ligament here. It's going to be actually to treat the pelvic floor to take that stretch off of it in the first place, right? So again, pelvic floor mobility is going to be really helpful in this to have more of a reflexive effect on the inguinal ligament, the iliopectineal ligament, as well as the blood flow to the pelvic arteries. In the pelvic floor mobility, I love is like self-massage with a soft ball. You could do just a prone stretch of the adductors. You could do a supported adductor stretch, like a frog stretch. You could do a standing or a half kneeling hip flexor type stretch with your leg out to the side, focusing on that hip abduction. There's a lot of options that you have from a pelvic floor standpoint.